Hello, I'm Dr. Daniel Kelly, director and one of the four founders of Pacific Neuroscience Institute here in Santa Monica, California. And today I'm going to talk to you about the surgical management of intracranial meningiomas with a focus on keyhole minimally invasive removal. Well, the surgical management of intracranial meningiomas has really evolved over the last century, and the procedures used for their removal have become increasingly refined. And I'm going to focus today on our use of keyhole approaches and the keyhole paradigm for all intracranial meningiomas. By way of background, it's important to know that meningiomas are the most common primary brain tumor. They occur much more frequently in women, and they arise from the brain coverings or the arachnoid. And here are some examples of meningiomas in the under the frontal lobe, around the area of the pituitary gland, so-called tuberculum cella meningiomas, cavernous sinus and petroclival meningiomas, and what we call convexity meningiomas. Um, about 10 to 15% can be aggressive, either atypical or anaplastic. They're often invasive into dura, bone, and the skull base, such as in this example here. And their surgical removal is really the treatment of choice for the vast majority of meningiomas. And if incompletely removed or if they recur, they may warrant additional treatment. And that second line treatment is typically focused radiation or radiosurgery. The symptoms associated with meningiomas are quite varied and again dependent upon location. So patients may present just with headaches. Seizures are very common, such as in this patient with a large frontal meningioma causing a lot of edema or swelling in the brain. Personality changes can occur, weakness or paralysis if the motor areas are affected. Vision loss and double vision are quite common for tumors that arise in and around the pituitary gland and the skull base here, affecting the optic nerves or the cranial nerves that move the eye. Facial pain we see quite often in tumors that are abutting or compressing the trigeminal nerve, so-called trigeminal neuralgia. And then large meningiomas, particularly in the posterior fossa, pushing on the cerebellum, can cause incoordination and imbalance. So again, a wide variety of presentations depending upon the location. And so our surgical approaches are very much dependent upon the location, but our goal is always maximal safe removal with reversal of neurologic deficits and complication avoidance. And we find that in the great majority of meningiomas, we can use these minimally invasive keyhole routes in most. For some convexity or surface meningiomas, these can also be removed through very tailored approaches, given the use of navigation and ultrasound. So what is keyhole surgery? Well, it's really the concept of removing tumors through smaller, more precise openings to minimize brain, bone, and scalp manipulation, often with the aid of endoscopy or surgical telescope. And this allows us to do the openings through smaller incisions with less bone removal, less soft tissue disruption, and typically without brain retraction. And so we really achieve a physiology preserving approach, leading to less collateral damage, a more rapid recovery, and in most cases, a shorter hospital stay. So our use of these traditional skull-base approaches, which are still relatively commonly practiced for meningiomas at many centers, we find we don't need to use these very often, very infrequently, and really have been replaced by these keyhole approaches. And so these include the endonasal endoscopic approach, so through the nostrils, completely with endoscopy for midline meningiomas. We use the supraorbital eyebrow approach, which I'll talk about in some detail, for a wide variety of meningiomas in the anterior part of the cranium. The retromastoid approach, or a small incision behind the ear, for meningiomas in the posterior fossa. Gravity-assisted approaches for meningiomas that can occur along the midline and are hard to get through coming from the same side, and this allows the brain to fall away with gravity assistance, and I'll show you an example of that. And then rarely for meningiomas that arise within the ventricle or the fluid-filled chambers of the brain, we can use a brain port approach through the brain to remove these deep-seated meningiomas. One of the keys to this keyhole paradigm is the use of endoscopy. And these are four examples of endoscopic images here showing a very calcified meningioma being removed through the nose. This is the pituitary gland and the pituitary stalk. And you can see we have a beautiful view of the anatomy here and able to remove this tumor completely. This is an olfactory groove meningioma in the frontal fossa. And with the endoscopic view, we can get a beautiful view of the olfactory nerve, the smelling nerve, and we can preserve that with this angled view that we get with the endoscope that we simply can't get with the operating microscope and the tunnel vision that comes with the operating microscope. Here's a meningioma attached to the tentorium sitting above the cerebellum, and with an endoscopic view, we can get a beautiful view and appreciation of the anatomy of the meningioma attached to this tentorium, and we can remove that completely. And then here's an example of this meningioma using a gravity-assisted approach and looking across to the other side of the brain and able to remove this meningioma with this angled endoscopic view. We have a long track record in publications related to meningiomas, and this is just a sampling of our publications that address meningiomas in different places throughout the brain, using, in most cases, this minimally invasive paradigm. So the criteria we use for the optimal approach, we look at the anatomy of the tumor, the access provided by the different routes, what are our surgical goals, whether the patients had prior surgery or other treatments, and their overall health. And so these different approaches that we may select are really dependent upon all of these factors. And if we take, for example, a very common location of meningiomas around the skull base in the midline, so-called paracellular meningiomas, there's quite a few different varieties here, and these are 6 different cases. And you can see that for 2 of these cases, we used an endonasal route. For 2, we used a supraorbital route. For 1, we used a mini-pterional route. And then for another, this one affecting a trigeminal function, we used the retromastoid route. So again, location is very critical in determining the best keyhole approach. The supraorbital route is the one that we use most commonly for meningiomas, just because a lot of meningiomas occur in and around this area, around the orbits, around the pituitary gland, under the frontal lobe. And this approach allows us this small incision through the eyebrow to reach the meningiomas without a retractor, and in many cases remove the vast majority of the entirety of the tumor. And the endoscope is really critical for these approaches. And so here's just several examples of meningiomas that we have removed through the eyebrow incision all around the what we call the frontal fossa, this area under the frontal lobes and over the orbit and around the pituitary gland. So a very good route for these commonly located meningiomas. Here's just an example of what we call a planum meningioma, very large meningioma in a 65-year-old woman. You can see the significant brain distortion here. And this is post-operative day 1 after removing through the left eyebrow and a complete tumor removal. Here's an example of what we call a convexity meningioma, causing some edema in the left frontal lobe, a lot of brain distortion here. And this patient had a receding hairline, and he specifically wanted an eyebrow incision. He did not want a big incision, which would traditionally be done behind the hairline. And this shows the footprint of the tumor based on the navigation. And this is the incision through the eyebrow. And this incision heals very well. This is him a few days after surgery. And he is now more than 5 years out from surgery without a recurrence of his meningioma. And overall, as we just published in 2020 with a large experience of our supraorbital eyebrow craniotomy, the cosmesis or the healing of the eyebrow incision is quite excellent in the vast majority of patients, as shown by these relatively happy patients and willing to show us their incisions here. But we can't do all of these through the eyebrow. And here's an example of what we call a tubercular meningioma in a 46-year-old woman who had very rapid onset of vision loss. And you can see that the optic chiasm is really lifted up by the tumor here, sitting on top of the pituitary gland. And it turns out when this woman was further evaluated, she was pregnant. And we know that meningiomas can grow during pregnancy. She already had 2 grown children, and she was quite surprised she was pregnant. But in fact, she was pregnant, We waited until the second trimester, which is the safe time to do surgery on these meningiomas. And we did an endoscopic endonasal approach because she had tumor coming out the left optic canal, really impacting her left eye vision. And this gives us the best route for these skull-base meningiomas affecting vision. That's the approach we used. This is her postoperative CT scan from the recovery room showing the reconstruction, some packing in the nose, some fat in the area where the tumor was. This is her MRI, which we could not use gadolinium because she was still pregnant when she had the surgery in the second trimester, but showing a complete removal. She went on to have a marked improvement in her vision, and her 6-month postoperative MRI, 1 month after delivering her baby, she had no evidence of residual tumor and normal pituitary gland function, most important, and a really nice recovery of her vision. And this is our happy patient here with their baby and the husband and Dr. Griffiths and I. So this is really a nice story, and this is really emphasizes how we can do these minimally invasive approaches so effectively, but the location is so critical to have a good outcome. Here's another example of what we call a Falx meningioma. This dural membrane that runs through the middle of the head is often a site where meningiomas arise. This woman had acute onset of left-sided sensory changes, and you can see all of this edema in her right parietal lobe here from the meningioma, causing a seizure and sensory changes on the contralateral side, on the left side. So this is tough to get to because it has a lot of brain overlying it that's very edematous. If we just came in on that side, we would probably injure that brain, and that would be a real problem. So in this case, we used a gravity-assisted approach by putting the patient on her side. This allows the brain to fall away, and then coming in, such as this is shown in this drawing here, we can reach this tumor without manipulating the contralateral side and the edematous or swollen brain overlying the tumor. And this is her postoperative day 0 from the recovery room CT scan, showing this craniotomy on the left side to reach the right-sided tumor. And you can see a complete tumor removal here. And she went on to do very well. This is 1 year after surgery. All this edema has essentially gone away, and she has no evidence of tumor recurrence. So a very nice use of these keyhole approaches to remove these tumors. So we've had a number of publications recently. This is our series of 3 tuberculum meningiomas in pregnant women that we use the eyebrow approach in 1 patient and the endonasal approach in 2. And this is a relatively large series of elderly patients or patients 65 and over that we use minimally invasive approaches for this large group of patients. And with very, very good outcomes, short length of stay. And notably in this paper, we looked at our meningiomas that we did not operate on, and approximately a third of the meningiomas we see actually don't need surgery. So that's an important point. Not every meningioma needs surgery. People get MRIs for all sorts of reasons, and sometimes we may discover a small asymptomatic meningioma, and we just leave those alone and keep an eye on them with regular MRIs. For some of these highly invasive meningiomas of the skull base, we know we can't get them out completely safely if we try to. This has been tried in the past. Patients wind up with significant neurologic deficits or strokes. And so in these very invasive paracellular cavernous sinus meningiomas that invade these compartments with cranial nerves, we do a very conservative debulking. We've had a very good outcome with these cases. This is just an example. A 59-year-old woman with this very invasive tumor in the midline skull base involving multiple compartments who presented with imbalance and some facial numbness. And so we did an approach through the nose to take the pressure away from the brainstem and take out as much tumor as possible. And this is her postoperative imaging showing a good decompression, but still significant tumor remaining. She went on to get radiation, and she's actually now more than 4 years out. Her tumor shrunk a little bit. She has no symptoms and is doing very well. So this conservative approach for these invasive skull-based meningiomas really seems like a reasonable approach. And then here's a large meningioma in the posterior fossa, this area around the cerebellum, pushing in on it, causing incoordination and headache. in a woman. Here she is 3 months after a retromastoid, small incision behind the left ear. We did leave a little tumor behind in this large blood sinus called the transverse sinus and sigmoid sinus, but she's gone on to do very well. And then another smaller meningioma here. This is a meningioma causing trigeminal neuralgia, right-sided facial pain. And this is nestled in the very intricate area, somewhat difficult to get to, but through this small retromastoid incision behind the ear, we were able to get the vast majority of the tumor out. And she had complete resolution of her facial pain and doing well more than a year after surgery. Finally, an intraventricular meningioma. These are quite rare, but here's an example of where we actually have to make a path through the brain to reach this tumor in a woman who had a first-time seizure. And we use what's called MRI tractography to look where the motor and sensory fibers are to find a safe pathway to the tumor. And in this case, we found a safe route through the parietal lobe, through what we call a transsulcal route. And this kind of surgery is augmented with navigation, tractography, as I said, and the use of the endoscope through a little incision like so, and working through a small fold in the brain and deepening that to reach the tumor. The tumor was able to be removed completely with the aid of the endoscope. And she's gone on also to do very well with a complete removal and no recurrence for more than 4 years. The recovery time for meningioma surgery in our hands at Pacific Neuroscience Institute, the surgery usually lasts anywhere from 3 to 8 hours, sometimes even longer for a very complex tumor, but usually on the shorter side of the 3 to 8 hours. Blood loss is usually relatively minimal. It's very rare that a patient need a transfusion. Most of our patients do not go to the ICU. They recover in what we call the step-down unit. We do an MRI on postoperative day 1. And most of our patients now are able to go home on postoperative day 1 or 2, occasionally day 3, but the majority on day 1 or 2. And they see us for their first neurosurgical postoperative visit, usually 7 to 10 days after surgery. In terms of activity, they can be up and walking on day 1, but nothing too strenuous for the first week. Flying is okay, typically after 7 to 10 days. They can drive after 10 days to 2 weeks, and really anything goes after 3 weeks, including exercise. So generally, a relatively rapid recovery from these keyhole approaches. So in conclusion, I'd just like to emphasize a few points. First, given the wide variety of locations, we need a variety of approaches, all of which stress maximal safe removal. The application of endoscopy, navigation, ultrasound, refined instrumentation, all of these technical adjuncts have really collectively advanced our meningioma surgery. And for the great majority of meningiomas, these keyhole approaches and the keyhole paradigm seems to work very well. Although we do occasionally still need to use traditional approaches, and these can be also done very effectively and safely. At our Pacific Brain Tumor Center, again, we have a large experience with meningiomas, and we're happy to see you if you have a newly diagnosed meningioma, if you have a recurrent or residual tumor, or if you'd like to get a second opinion. Thank you very much.